I'm Lucio Buratto from Milan, Italy. I started phacoemulsification on 78 and posterior chamber IOS on 79. And I started refractive surgery in 84 and keratomileosis in 86 and laser treatment for myopia in 89. So I have a long experience in cataract and refractive surgery.
Okay. What would you say are some of the most important innovations that have increased the safety and the efficiency of cataracts?
In my opinion, the most advanced phacoemulsification has changed the life of many patients and surgeons. Before phaco, patients used to go to the hospital, have general anesthesia, having surgery without IOS. Really, phacoemulsification changed everything. Now the patients are demanding more and more, and because we really are able to give more than before, now we can really offer cataract refractive surgery, and we can do our best to remove glasses from people. No, so it's not only cataract surgery, but is, I would say, more and more refractive surgery. We had several advances on time. In viscoelastic, for example, they are helping a lot during surgery. They really give us the opportunity to have a very safe surgery to protect the structure inside the eye. They allow us to keep spaces and allow the IOL insertion in a safe way, and we can really protect in a very good way our eyes during surgery. Another big advancement is on IOLs. We started from a really simple IOL. Calculation was very rough, I would say, at the beginning. Now we have really very good IOLs. We have perfect instruments for measuring the eyes and keratometry and axial length and everything. So our calculation is much more precise. And with the new IOLs, we can really solve many problems like astigmatism with toric IOLs, presbyopia with multifocal EDOF or bifocal lenses, or by using other technique like monovision, for example, is very good procedure. Simple one, but offering very good results. We had another big improvement when we had capsulotomies performed in a very good way. When we used to do the can opener technique many years ago, the lens couldn't stay inside the bag. Now with the Rexis and much better with the femtosecond laser, we can really obtain a very circular, perfect, centered capsulotomy that give us the opportunity to introduce the lens in the capsular bag in a very well-positioned, well-centered, and offering very good results for our patients. But cataract surgery is not only surgery. Most of the results are good if we really take care of the diagnostic part of the patient. We have to really carefully check the cornea of the patient, see if it is regular or irregular, if it has scar or something else. We have to see the retina very well, especially the macula, if we want to put a multifocal IOLs, for example. We have to measure also the aberrations and the angle kappa. We have to take care of everything. And another point is we have to really learn a lot from the patient. I mean, our patients are asking more and more, but we have to understand exactly what the patient wants. So we have to spend a lot of time talking with the patient, asking his needs, and after we understand what the patient needs, we really can offer him the best.
Where do you see opportunities for further improving outcomes and the efficiency of cataract surgery?
Now we have super microscopes. Our phacoemulsification machine are very, very well performing. We have the femtosecond lasers, soften the cataract, performing a nice capsulotomy and nice incisions. And these are really very good things for our surgery. And everything of this is bringing better results for the patient. And our efficiency is increased by using also simple but very good instruments during surgery, like knives, forceps, scissors. And we have more and more precise, fine-tuned instruments that can help us solving little problems that we can have during surgery. Efficiency in surgery means also timing. We have to schedule the patient in a good way to keep them not waiting, but to have especially the staff working in a proper way. I mean, it's important to have to give the right time to each patient, to give the right time to the staff to work for the patient. And so we have to schedule the patient depending on the difficulties they can have during surgery, depending on the quality of the operation that we have to do. If it is a simple cataract, it can take 15 minutes between this and that. If it is a hard cataract with small pupil, glaucoma, etc., we have to dedicate much more time. So efficiency means also scheduling very well the time during the surgical session.
What role does improving efficiency play in the ability to meet the growing need for services? There's a growing need for cataract surgery. Yeah. What can be done to improve the productivity of the of cataract surgeons, particularly since there aren't enough of them being trained?
I mean, many years ago when we used to do cataract surgery, we had general anesthesia, phaco was long, anesthesia was a general. We used to spend a lot of time with our patients. Now with topical anesthesia and intraocular anesthesia, patient is suffering much less first, but the most important part for our surgery is that the surgery is much shorter in timing. Also because the phaco machine is performing better and we can soften the lens before surgery, so the surgery itself is a little bit easier and simple and faster, and so really we can perform much more cases. When I started phacoemulsification more than 30 years ago, I used to do 4, 5, 6 cases in the morning. Now I can do 12 if I want, or more than that, in the same time I used to do before, because the surgery itself is much more quicker, much more safer, much more precise and organized by the staff. Also, the staff is much more efficient because they learn everything, how to use the machine, etc., etc. So, and also depend on how many operating rooms you have. I have 3 operating rooms, for example, on a laser room, and I can schedule a patient in one room, and as soon as I finish the first one, I can switch to the second one, and I have another doctor performing the femtosecond laser before surgery, so I can really find my patient ready in the operating room, ready for surgery, I mean. And so it's becoming more and more efficient. My staff is working very, very, very well on that. And we have two femtosecond laser machine. We have 4 phaco machine. We have plenty of surgical instruments to be able to perform many cases without having to wait for, let me say, because the room is occupied or because the instruments are not sterile or everything. And another thing is that more and more I think the companies producing instruments, they have to look for one single use of instruments. I mean, now it's timing for the technology is able to produce disposable instruments for surgery, and this can also make the surgery faster because you don't have to clean, you don't have to sterilize, and etc., etc. And it can also be a little bit safer for the patient because there is less risk of transmitting something from patient to patient.
It sounds like teamwork is very important to being efficient. Teamwork, you have a team that works together. Can you tell us a little bit about how you train and keep that team working together?
We found a big improvement in our staff efficiency when we started having a meeting every couple of weeks. We divided the staff in 4 teams. One is the technical staff. The other one is the doctors. The other one are the administration. The other one is the patient, organization. Now we do, once a month we do a meeting with all the 4 groups, and every 2 weeks we do a meeting with every single group, and we discuss what can be improved during our everyday activity, also in diagnostic, or in talking with the patient, or in preparing the patient for surgery, or talking about IOI calculation or refractive programming. What we also do very often is we prepare clinical cases. When a patient is coming to us to see us, and when we see that it's not a very simple and regular patient, it has some, let me say, particularities, we study this patient, we prepare a clinical case, and we discuss with the staff the clinical case. So the nurse, the young doctor, and the older patient, older doctor, can really have the same kind of information. This is growing a lot, on staff efficiency and staff information, staff, knowledge on what we are doing during everyday profession.
Can you tell us a little bit about some of the instrumentation work that you've done, or tools that you've helped develop that have improved?
Manual instruments.
Right.
Every surgeon needs special instruments because he is. Let me start again. From the beginning of my profession, I realized that I needed some special instruments for performing better surgery. So, since many years, I started designing instruments, and I realized many instruments during my surgical profession, more than 200. I like to really design instruments because it allows me to do better surgery, more precise surgery, more controlled surgery. If I have the right forceps or the right knife or the right scissor, I really can my surgery better, and this is more efficient and it's more rapid and more safe for my patient. So I think that the surgical instruments really needs to be at the first quality because if you want to do first quality surgery, and this helps also the surgeon a lot because the surgeon is much more confident when he knows the instruments, when he exactly knows how to use it and how to obtain the best from that instrument.
Have you worked with a Zico on that?
I started cooperating with a Zico many years ago. I would say 50 years ago. And, I have a little bit of problem in design with a Zico because I'm living in Italy and design and sending design drawings to United States and the instruments back is quite a little bit difficult. But I really enjoyed working with Zico because there is a very updated company, really taking care of their instrumentation very carefully. They are really realizing good instruments for doctors, for our surgery, and I feel very, very happy to cooperate with Zico on design new instruments.
Is there any instrument in particular that you've designed or worked on that stands out in your mind as being especially important?
Yes, I like in the last period I designed a couple of pre-choppers for femtosecond cataract surgery. Because when we do femtosecond and we divide the nucleus, let me say, in 4 steps, in 4 quadrants, I like before starting phaco to enter the eye and really divide really completely the pieces. Also, this allows me to perform a quicker surgery and a little bit more controlled surgery. So my phaco machine is not so important like it was in the past now because I have the ability to really prepare the eye with the femtosecond, with the pre-choppers, with everything inside, with the viscoelastic inside the eye. I really can obtain a more controlled surgery. Also, I design many forceps for capsulotomies. I design many instruments for holding the lens or folding the lens on the past. Now, the last design is forceps to fold an IOL inside the eye when you need to explant. Sometimes we have to explant an IOL because it is, let me say, a phakic IOL. There is a cataract and you have to do cataract surgery and you have first to explant the IOL. Or because the patient is not happy with the multifocal IOL or toric IOL, etc. Sometimes in our profession we have to exchange an IOL. I don't like to cut the lens inside the eye. I prefer to fold it and bring it through a small incision. And it works very well. I mean, I'm very happy about that forceps.
Okay. Going back to the pre-chopper for the femtosecond surgery, what is the issue there? That the laser doesn't get all the way through the lens?
Yeah. Exactly, I designed two pre-choppers. One is for soft cataract, because when you do the femtosecond, I do all my cases with the femtosecond laser first. When I do the femtosecond in a soft cataract, I liked anyway to divide the nucleus in pieces. So I need, let me say, a little bit thicker and not cutting pre-chopper. When I have a very hard cataract, I need a completely different pre-chopper, because the cataract is hard and I need to enter inside the grooves with the pre-chopper and to divide the nucleus. And after, with the same instruments, I like to rotate the nucleus inside the capsule bag. So I should be also able to rotate the nucleus. And after, I divide the other 2 pieces. And really, this is allowing me to have a very safe surgery. I must say that in the last 2,000 cases I did, I broken 1 single posterior capsule. That because of the femtosecond, because of good instruments, because of the phaco machine is performing very well. I mean, I used to do some posterior capsule breaking before femtosecond. Not many, but 3-4%. It was almost, say, normal. Now, really, with the improvement of the instruments, better microscope, better viscoelastic, better manual instruments, etc. Really, complications are much more rare. I will say that today the complications are more refractive complications than surgical complications. What I mean is sometimes the patient is asking for a plano refraction and we have maybe one diopter of astigmatism and the patient is not happy. Or there is a little myopia or some hyperopia, or because of lens positioning, the refraction is not perfect. It might happen that the patient is not obtaining really the refraction he wanted. But these patients are more and more unhappy when we really are unable to give them what they want. So it's really important to try at least a good surgery, try to do at least the best, diagnostic to be able to do a very good calculation. And it's also important to use the good instruments during surgery. What I mean, the device, for example, for positioning the toric IOS, I use the Varion on the Callisto. They do very well. I mean, they allow me to really position the lens in the right axis for correcting the astigmatism. So there are so many little steps, little points that are very important during surgery. It is not just performing surgery. 30 years ago, 20 years ago, 10 years ago, it was just enough to do cataract surgery, putting a monofocal IOL on the patient. Our patient was very, very, very happy. Now, when we do our best, the patients are happy, not very, very happy, because they are really asking everything.
So it's a never-ending journey. The better you get, the better they want you to be.
Exactly.
Yeah.
Also, there is also due also to the doctors, because to have more patients and to increase the practice volume, the doctor tends to offer more than they can really do.
Yeah. So you have to be careful about that, I guess.
That's another problem.
Yeah. I guess that new instruments doesn't really help that. Anything else? Where do you see ophthalmology going in the future? You've been at it for a long time. What do you see the future being?
More and more we will use technologies. I mean, artificial intelligence is becoming a reality now, more and more. We have more and more instruments that are performing better diagnostic especially, better surgery, better. And we are also working on 3D now. So surgery is also changing, becoming more and more robotic. And the surgeon is, I will not say that he's doing less, he's doing different. For example, now we have better injectors for the IOLs. With the Zico, we designed also injectors for IOLs. The IOLs now can really enter very, very well, very softly, without being damaged, without damaging the internal structure inside the eye. So I think that intelligence, artificial technology, and the better instruments, and they really is the future of surgery. In my opinion, being a little bit more, let me say, optimistic, I think that in a long future, the patient can enter in the office, put a credit card in a machine, having a big machine diagnostic his situation, and another machine really preparing the eye for surgery, lasering the patient, performing the refraction correction, doing softening of the cataract, maybe removing of cataract, maybe putting a lens that can be correct everything. If not, we have a technology with which we can correct refraction after surgery with changing the power of the iris inside the eye. And we will have also multifocality. The day we will have a really good lens that can give to the patient near vision, intermediate vision, and long, far vision, really ophthalmology is at the maximum option for the patient should be the best. And if we can obtain that, every person who has a little refractive defect or has a cataract or has other problem can really be solved very, very quickly and very safely, especially very precisely.
Okay. Anything else that you'd like to add?
I think that we had too much.
Okay, great. Well, thank you very much.
Thank you.